Okay, everyone, let's kick off then. First of all, welcome. Great to see you, particularly in a kind of a busy week, sort of heading towards the holidays. We had a half a dozen or so apologies, which we'll record in the minutes. Does anyone want to mention any other apologies that they're aware of?
William, I just wanted to mention that unfortunately Catriona can't join us today. So with regards to sort of the research update that she was going to share, but she's really keen to come along to the meeting perhaps in March.
Okay, so that's item 8 that will be shifting to March then.
Yeah. And I'll also be doing the comms update on behalf of Jill. She hasn't been able to join us today, unfortunately.
Okay, thanks. I think that covers all the changes to the agenda then. Okay, let's move on then to the action log. Okay, first one I'd just like to pick up on is number 48, which for those of you who don't have it in front of you, it's about linking back to the personalised care event earlier in the year. Asking all of us to, if we have links with community groups, etc., to identify them and potentially pass those names to Lisa, so she could pass them on to Salman because of the kind of the work that he's doing around Cancer Buddies. So I just want to remind people of that. Lisa, do you want to add anything to that?
Just to say that I hadn't received anything directly, but that isn't to say that people hadn't automatically sent it to Salman. But it was just as a reminder that obviously following our June event, everybody was very keen in sort of promoting and kind of backing the health inequalities agenda that obviously one of our work streams as part of TVCA has. So if you want to just catch up with me directly because you're not quite sure as to who you're networked with and whether or not they would be relevant, I'm happy to have that conversation with you separately, or else I can again share Salman's email and you can contact him directly.
Okay, that's great. I'll be saying something briefly about the NCPES later. So I don't think there's anything else I want to highlight from the action log, unless anyone has anything they want to raise. No? Okay, thank you very much. Okay. Then we're on to item 3. The item 2. We've got Luke joining us. I hope. Luke, are you with us?
I'm here. Yes.
Oh, welcome, Luke.
Thank you.
With you then.
Right. Shall I kick off?
Yes, please do.
Brilliant. Well, I must say thank you very much for inviting me to join you and to just give you a little update on the mapping report. So we presented this at the TVCA showcase event on the 7th of November. This whole project has taken a couple of years to put together, and I must say I can actually see Daffyd in the corner there on my screen. Daffyd's been involved with the report, was very kind to actually have contributed to it and reviewed the report for us before publication. So thank you very much, Daffyd. We are very grateful. And you've got a really fetching Christmas jumper from what I can see. So I just wanted to mention and just talk you through some of the highlights of the report and possibly ask for some feedback. So William, I'm not quite sure, will we be able to have just 2 minutes for a bit of a discussion? I've only got about 10 slides. Yeah, because in some ways I think one of the things that we really would like to start to think about is how we can use what we've pulled together in the report in order to influence improvements in care, because I think that was the whole point of putting the report together. So I'd really welcome your thoughts and any suggestions you have. So Lisa, can I actually move my slides forward? Oh yes, I'm able to do this. So for the people who don't know me, I'm a consultant psychiatrist. I work in the Oxford Cancer Centre at the Churchill Hospital. And I think I worked with the TVCA on this report for over a couple of years. And as I said, it was launched on the 7th of November at the showcase event. This is what the report looks like. It's completely online and it's available on the TVCA website now. I could ask Lisa to put this into the chat, or I could do that after this talk so you can access it if you haven't already seen it. It looks at provision of psychological care services across each of the sites. So Oxford, Buckinghamshire, West Berkshire and Swindon. Frimley were part of the process, but they asked, I think, in about May or June of this year to, be taken out of the process because they've joined a different cancer alliance to do their mapping project. So it involves most of the sites across the TVCA. And this is what we set out to do. So 5 very simple objectives to map clinical pathways. So it's always helpful, especially, when we've got MDTs, we've got, lots of clinicians who don't necessarily sort of, speak to each other or work closely together. We thought we'd actually follow patient journeys to see, where people entered the cancer pathway and where they exited across each of our cancer centers. And then we mapped out what staff and services were available, both NHS as well as in the voluntary sector. We've tried to highlight areas of good practice. I think we probably are delivering really high quality care, and there are lots of very exciting things. For example, the cancer champions in Reading. There's a lot of really good work that's happening within the TVCA region, but I don't think we are aware of what is happening and the impact of this, and we've tried to highlight that. We've also tried to estimate demand and flag up what the gaps in service provision are. And all of this is to inform sort of people who are going through cancer treatment. So if they are looking for support, they're able to look at the report and say, what's available in my local area around my cancer center? How do I access it? Clinicians, because a lot of the time, so, colleagues of mine in Oxford and elsewhere have no idea about where they can refer people. And it's surprising how common that is. And finally, the people who are most important to all of us, who are the people who hold the purse strings. So our commissioners to say we have to make the case not just to be treating people's tumors, but also to be looking at the person as a whole and to develop services, especially where there are gaps in the service provision. Just very briefly, I think there's a whole section about the methodology. So we met up each of the lead cancer nurses and the psychological care leads on each of the sites were part of the steering group. We met with all of them. We sent out a series of questionnaires and collected data. And this, I think, went backwards, forwards a few times in order for us to get the most accurate and clear data. Most of the work was done over the course of 2022. So you'll say, well, we're in 2023. And yes, this is part of the difficulty when when you're doing such a detailed exercise, that a lot of things change, data gets out of date, but I think we've tried our best to capture the most relevant data. And we've got 3 separate sections. So, we've got separate sections for patients and families to look at. We've got a separate section for clinicians, separate sections for commissioners. And we've also got recommendations which are very specific. I've got a slide about that and I'll show you this. I think figures by themselves are very dry, and I think as somebody who's been around a few years, been talking to commissioners, been on boards, I think nothing illustrates difficulties like having powerful sort of personal experiences. And I think this is where David, with his personal experience, and Sarah Hepworth with her experience, they demonstrate what we're trying to bring to life through this report about the implications of cancer treatment, not just on the patient, but on the wider family and how it impacts life as a whole. And I think these are very powerful sections of the report, and I'm very grateful, David. It takes a lot of courage to actually put yourself out there. So thank you. This is how we mapped our patient journeys. So you can see we've tried to follow things through and try to indicate where people can access support, where they are being referred on through their pathway from the time they're referred in from primary care to the time they have their sort of cancer care reviews in primary care again. And we've broken things down into quite a lot of detail in terms of numbers for each of the cancer centers, which in some ways gives us as planners of services and commissioners of services a fairly good idea about what the need is going to be. We decided to use 2019 as our sort of base year because that was the year before the pandemic, where I think the numbers were as close as to what they probably are year on year, and kind of added an 11% year-on-year increase as a kind of as one way of being able to predict what the demand's going to be going forward. And this is quite a busy slide, but I've put this up just to show you that I think we've got fairly detailed recommendations and also timeframes, and we've tried to actually say, well, who's responsible for moving each of these recommendations forward, so we can hold specific people within the TVCA, hold them to task and actually give them timeframes to work towards. And you might say this is very easy to be putting in there, but I think in some ways it also gives the entire system a bit of a framework to work towards. And I think the areas that we flagged up as priorities are protected time for all our CNSs. So our specialist nurses probably see the biggest number of people who are struggling with their diagnosis, who have comorbid psychiatric, psychological problems. Being able to get them time to have training, time to have supervision, so they're able to then support their patients better was one of our priority sort of areas. And the other sort of priority area was thinking about substantive contracts. So a lot of the staff who work, say in Reading, say in Swindon, do not have substantive contracts. So, they are literally re-employed year on year, and that just doesn't help with them being able to plan or deliver a service. And I think that's something that we're asking for, alongside also patients who are on regional pathways, so patients with sarcomas, patients with, say, skin cancers who are needing immunotherapy, who come to Oxford for their treatment, but otherwise wouldn't have any local support again. So we've highlighted these areas as our priority areas to focus on. I'm not going to go into the other recommendations, but please look at these when you look at the report. And I think this is my last slide. Just to say we've actually broken our recommendations down even further of 2 individual sites. So wherever you are, I can see somebody from Health Watch on my screen there. You can actually be looking to see what the gaps in service provision at your local sort of cancer centres are. and hopefully start to think about how we can come together as a system and try and address them. And I think that pretty much was it. So thank you very much for listening, and I'd really welcome your any sort of thoughts and comments you have.
Thank you. Thank you, Luke. Anyone got any sort of comments or questions for Luke? Patrick?
Yeah, just a couple of quick ones. Thank you very much for that, Luke. It just strikes me as being such a crucial report that is sadly lacking, but it certainly seems like you filled a gap. Just two questions, really. Firstly, was there any patient involvement in the putting together and compiling of the report? But perhaps more importantly now, it's the so what question. What do we now need to do collectively, all of us, to try to ensure that this report actually leads to improved outcomes for patients and their families?
Yes. So let me deal with your first question, Patrick. So I think Lisa's been involved with the mapping project from the outset. And I must say this is it's a bit embarrassing. So we actually did have a section in the report where we actually put out a survey to a lot of our patients and families. I think this was in the summer of 2022. Unfortunately, we did not get a large number of responses. So I think we had about 20 responses, and that was very unfortunate. And we should have done things a bit better. And after that, I think we've had David, who actually reviewed the report for us, looked at its legibility, and I think had comments about things that we could have added in. The second thing, in response to your second question, what I think, to a clinician who works within the system, I think a lot of the time I am speaking to my oncologist colleagues, to the lead cancer nurses. I can see Hannah on my screen here as well. Trying to sort of say to my colleagues, I think we are so caught up, especially with where the NHS is now, with our sort of, trying to just keep on top of wait lists, not going to the red, that the focus is very much on, saying, can we actually see somebody as quickly as possible, to only focus on their cancer? And sometimes being able to sort of broaden that perspective and think about things, look at the person as a whole, can actually make a huge difference. I mean, I think find that, somebody who's very anxious, somebody who's very isolated, tends to not do as well. I mean, we've got research evidence about this, and I think that's what we're trying to sort of, say to all our clinician colleagues whom we work with, to say, you've got to think about each of your patients as a sort of whole person. Don't just, think about that little tumor, then say, I'm going to treat that one little cancer, and hope that everything else will be okay. I think that's what we're trying to sort of get out there.
Okay, thanks, Luke. Shaman, did you want to come in? Shaman?
Muting. Oh, hi there. Sorry, it wasn't unmuting. Apologies for that. So for those who don't know who Health Watch are, so we champion the voice of the community, and we gather feedback about people's experiences attending GPs, surgeries, hospitals, etc. So I'm kind of fairly new, 6 months into my role as engagement officer, and I would just like to know in terms of gathering data, patient feedback from patients and families. Did you contact Health Watch, any of the local Health Watch branches?
We did, Shaman. So I think and you'll forgive me if I'm sort of being ignorant about this, but I think if I remember right, it was West Berkshire Health Watch who probably, were able to give us a lot of contacts, had a lot of detail. One one way we were hamstrung was we weren't able to actually approach our patients and their families directly. So we had to do it through Health Watch. We had to do it through the sort of Macmillan engagement officers. We weren't able to sort of do this directly because that is again something that we're not able to do as the NHS.
Yeah.
And I think that might be something, you know, I think we learn things for, you know, every time we do something. And I think in the future, that's something that I think we probably do a lot earlier and try and get a lot more engagement, because I don't think we did that very well. And it's something we discovered as the NHS. If we didn't have consent for people to, you know, if patients' families didn't consent to be contacted, we couldn't actually send them out a questionnaire. That was a difficulty.
Linda, you got a hand up?
Thank you.
Thank you for that. It was reassuring to see that psychological support is there. I'm just asking, I mean, I represent a breast cancer support group in Milton Keynes, about those cases where a Milton Keynes patient is referred to Oxford. They seem to fall between the two areas, and they don't get, I don't even know if they get a whole needs assessment at either end, and they don't seem to have an identifiable psychological support.
So that's something that you've actually reiterated what we've put into that report, where this is something that we found is a big gap. So patients on what you'd call a regional pathway, they fall between us and, you know, so Milton Keynes and the services there say, well, the person's having treatment in Oxford, so we can't provide any support to them. And in some ways, I think what we're asking is that, you know, the same way cancer treatment gets paid for when the patient comes to Oxford, the commissioners also say, well, we're going to pay for their psychological support as well, if you see what I mean. So we've got this provision. Yes. So the difference, Linda, is if somebody from Oxfordshire, you know, they get screened. So this is what happens. All our patients get screened when they come in for an oncology review. And if there's a problem, we pick them up very, very quickly. Somebody from Milton Keynes, they'll see me in my clinic, but because of how busy I am, it takes about 4 months before they get to see me. And I think after I've seen them, I can't really hand them back to anyone in Milton Keynes, because they say, oh, well, we really don't have the funds to provide any support because, you know, they're having their cancer treatment in Oxford. So that's something that we'd like to really think about.
So it's very distressing for the patient caught in the middle, because they don't know where to turn. And, yes. And I would also point out that possibly local cancer services should engage a bit more with support groups so that they are better able to advise, because it's quite hard to get information from the breast care unit. I am assuming that it's because they're so busy, because they have so many referrals, but there are times when it would be helpful for them and for us if we had a clearer picture of who could be doing what for whom. Yes. That's all, but otherwise.
So I mean, can I just maybe answer one thing, and Hannah probably will be able to confirm this for me. I think irrespective of, you know, where the patient's from, they will get a holistic needs assessment done by one of our specialist nurses in Oxford. But I think after that, as you've said, it's the difficulty across sites and how do we communicate? And this is always a difficulty. And it's always the most complex patients. I remember, you know, a young woman, she, you know, from one of those areas, I think Leighton Buzzard, you know, so she kind of falls between 3 counties. She did, you know, we discovered she had a cancer just after she'd had a baby. She was very unwell, and it was so difficult to actually get support for her because, you know, she lived between 3 counties, and this is a very valid point you're making.
Thanks, Luke. It's great to see so many people who want to speak in this, but could I ask you just to be brief so we can?
Yes, I'm sorry. I'm getting carried away. Yes.
I mean, I think.
Yeah.
When we're asking questions, we're really interested, and therefore, you know, it's naturally you want to go on. So, Kath, next, please.
Yeah, thank you. Great report, Luke. Couple of things. One is workforce. How I can see that you've got some dates in there up to 2025 as to when some of these some of the parts of the projects are going to be put in place. So workforce, obviously, you've got to recruit for. That may be a bit difficult. Reporting after, so I did read the report prior to today, and I couldn't actually see anything about monitoring the process. I may have missed it. So monitoring of how the project is progressing with the dates that you have in there, and also something slightly different is some people get diagnosed with cancer. I won't say overnight because it isn't, but it's within days or weeks sometimes of seeing a clinician. Sometimes those people need probably the biggest emotional support quickest. So that may be something that needs to be built in. And finally, just a statement really, is the differences between men and women accessing help for, you know, when they've been diagnosed with cancer. I think it's two quite extreme areas. One, you know, women do and men possibly don't ever. So that's something to bear in mind as well. I'm not asking for any answers, it's just some feedback. Thank you.
Thank you, Kathy.
Okay, thank you. David?
Yeah, just a few comments really, rather than any questions. I mean, speaking as a user, access is key, you know, to this sort of thing. I've been to lots of hospitals where they've got posters in waiting rooms. If you want to talk to somebody about X or Y, that's fine. But I was aware of what was available, and until the very end of my treatment, I didn't do anything about it. If somebody had asked me, why didn't you, I wouldn't have been able to answer. And it was only the final consultation during a scare at the end that a reasonably persistent senior reg got it out of me, you know, what was going on. So I think that is the key thing. I still think that was the major thing about the whole support piece, because that's the extremely useful thing, that you don't have to say, oh, what can I do about this? Because you're presented with an option, and then you realize, yes, I should take it up. So I think that's what I would say. Thank you.
Okay, thanks, David. Emma?
Hi, I'm engagement lead for Macmillan across Oxfordshire and Swindon. Just a reflection really, because these reports are fantastic pieces of work, you know, the culmination of so much endeavour, and just acutely aware that sometimes they're not as accessible to such a wide audience as you might hope for, and just was really thinking in a creative way that you could follow up these kind of reports with a bit of a video featuring a whole showcase of patients, and they could be talking about the report findings, the recommendations, the highlights, and what they would like to see. And that might almost backtrack you a little bit in the sort of deficits from that week survey. Just an idea, really. I'm not saying where the money's coming from to do the video.
I think that's an excellent idea, Emma. So Shelley, whom I worked with on this, so who used to be one of our deputy lead cancer nurses here. So Macmillan are doing an easy read version. So I think that'll definitely help. But I think that's an excellent idea. I might have to speak to Lisa and find a way of being able to do this and follow this through. But I think that's an excellent idea.
Okay, thank
very
you.
happy to pick up with Shelley and with Lisa.
What's your surname, Emma?
I'll put my contact in the chat.
Please, yes, and I'll copy you into an email to Shelley.
Okay.
Brilliant. Thank you.
Thank you. And Jazz? You there, Jazz?
Jazz. Yeah, hiya, I'm Jazz. I work for Health Watch Engagement Lead. Firstly, I'd like to say an excellent report, what you've done. And I think in terms of the customer, the journey of the patient, I think that's really, really important of what you've produced. And we've talked about supporting the patient. I was just thinking if you could have a leaflet or a directory of all the agencies that would enable to help somebody.
Yeah.
And lastly, it's what Emma is saying. Yeah, I think it's great, you know, to have real stories. In Health Watch, what we do is a simple format of a report. And I think that's really, it really sort of explains to anybody that's reading it. It's not sort of it's jargon free of the whole journey of what's happened, because I think it's really important when you've done such good work like this, is that, you know, you want to embed it within the organisations, and also that what people can see. That's really important.
Yeah. So
Okay,
two things to say very quickly. Sorry, William.
Hello?
So this is something that I think we've tried to do, Chaz, and actually say, you know, there has to be a directory, but it needs to be up to date, because a lot of this is what we found. There are a lot of charities who say they're doing things, but actually when you look, they aren't. So we've actually put that in as a recommendation, and I think I would like Health Watch to actually be saying this is something, you know, to hold charities accountable as well, because, you know, they say something and then 6 months later you actually decide you try to find the service, it's not there. And I think we put in our recommendations that, you know, we as cancer centers actually look at what's being provided on an annual basis, update our lists, because they are, you know, they're a big part of the support network available to our patients. So thank you for that.
Okay, thank you. I'm Sarah.
Hello there, I'm Sarah By, I'm Deputy Lead Cancer Nurse at CWH, Swindon Hospital. And I first saw this, I first saw this report when you presented it at TVCA conference. And I mean, it's a great report with a lot of work behind it. And I think we all wholeheartedly agree with the sentiment and also the absolute need for psychological support. We have great psychological support at Swindon, but it's not enough. We don't have enough staff to offer that service, which means that we have longer waits than we'd like. And it also means that our CNS teams, who I passionately care about and who actually deal with a lot, you know, they can deal with one cancer diagnosis after the next in a day, and they need support both for themselves to deal with that, but also to help manage the psychological distress of their patients, definitely in that time period when they're plugging before the sort of professionals actually were stepping. I think though, just in the spirit of kind of openness, I just need to kind of highlight that one of the things that we've been discussing here at GWH, absolutely we agree with all the recommendations, but we are struggling financially. The NHS is in a state. I know our trust is, we're having to save money this year. I'm even struggling now through my trust board to get, if someone leaves, I'm struggling just to get replacements. I'm having to really fight for every replacement. I know, talking to Hannah from Oxford, she's now struggling, and she's not the only hospital, so it's substantive posts when they're on a year fixed term contract. We're struggling to get those people replaced as well. So yeah, I just feel like although these recommendations are there, and absolutely it's what we're striving to do, it's in the spirit of openness, it's absolutely not a definite, this is what we'd like, it's not what we can guarantee we're going to be able to provide, I think.
Can I say something about that, Sarah?
Absolutely, absolutely.
So, you know, as somebody who has spent, I don't know, 15 years in trying to, you know, develop build services, I think this is the story of the NHS. And I think in some ways, you know, I come to this forum and I ask everyone here to actually support us in being able to make our case. And I'll pick up on what Kathy highlighted, which is, and I think this is what Sarah, Yumi, Hannah need to actually be doing, which is to say, what's the progress we're making? And, you know, being able to, you know, this is what I say to, you know, people in Oxford. Well, if you actually let us support our CNSs, we're going to have a lot less burnout. We're going to actually have a team that is functioning better. It's getting them to recognize this, but I think we're always asked, well, what kind of saving can you make? Well, actually, we make dramatic savings. You know, people don't use ED as much. They aren't admitted onto wards as much when we deal with their comorbidities. But it's very hard to actually put a number to that. And I think this is what we've got to keep pushing for.
Okay, thank you, Luke. I mean, I think the whole kind of thing about the funding challenges, I think, is, you know, as has been said, we can't ignore, and it's always more difficult to get things implemented, which are, you know, based on research, and, you know, some people say, well, we can't do this because we have to do that. But as Luke says, it's a constant problem. It just seems to be sort of even more reinforced at the moment. So, Luke, can I just, on behalf of all of us, say thank you very much for this presentation. I think you know, taking account of the number of people who have wanted to comment and question, I think just reinforces how significant we think it all is. So thank you.
No, thank you for letting me speak.
Okay, thank you.
Bye-bye now. Thank you.
Okay. So I'll be very brief over the next two items, which, so the showcase, first of all, what you see highlighted in yellow is, first of all, obviously what Luke has just presented, and then the second one about sort of child adult services and its side effects will be coming to later. But I think what you see there is a full list of the whole range of presentations that were made. It was a very helpful day. Unfortunately, I was the only patient there, but it was primarily a professionals conference, and I'd like, I suppose, in future to be in a situation where hopefully more of us could be there. And then the green items, David Fitzgerald's and the Cancer Buddy projects, are the ones that I'm going to be talking about briefly. So just picking out of everything that's there, those are the ones that I want to pick. Okay, David Fitzgerald, National Director. I think this is a very interesting slide. If you look on the left-hand side, you're looking at very much the whole kind of thing around the proportions of early diagnosis by incidence. Now, this is 2019, but you'll see we've got percentages along the bottom and kind of numbers up the left. And I think that gives you a clear indication of the huge variation.
William, can I just check? I think I can still see my slides, so I don't know if they're actually moving for everyone else.
No, I think are we still seeing David Fitzgerald's slide? Do people see a slide with two boxes on it?
I can see the highlights from David Fitzgerald.
Yeah, okay, yes, okay, thanks, okay. We've got the right one.
Fine.
So, you know, what David was highlighting was very much the whole kind of thing about, you know, if we're going to get to 75%, I think that's what we want to get to. We've still got a long way to go. And if you look at the on the right-hand side, that sort of red line is where we currently are. I think it's, can't quite see, but I think it's below 60%. And he's obviously wanting to get to 75%. So it's great that we're having a focus on early diagnosis, but clear that there's still a long way to go. Next slide, please, Lisa. Okay, and again, reinforcing the early diagnosis, and what he's talked a bit more about the strategy. And the boxes on the right, I think, are very much highlighting. These are the kind of key elements within the strategy. And then the percentages are the estimated impact if we achieve those various elements that they might have. And that's reflected a bit more over on the left-hand side. And I think it's important to, you know, reinforce that point at the bottom about the historically there, you know, 8 to 9% gap between in early diagnosis between the most and least deprived areas. So it's really important to focus on disadvantage, and that's what David was highlighting we want to do. Next slide. Okay, this is just very much focusing the whole kind of thing about, as a result of that, if we're going to achieve that, what sort of investment do we need to put into advertising campaigns? And you'll see some of the points on the right-hand side of the box. Okay, I'm not going to say anything more on that unless anyone has any questions about any of the slides, which I may be able to answer, but I may not. Anyone got any thoughts or comments about those slides from David Fitzgerald? No? Okay.
Are the slides available?
Please.
I just wanted to say that the slides are from the whole of the showcase are on our website, and within this slide pack, I've put a link to that. So when they're circulated afterwards, everybody will be able to go and actually have a look at the comprehensive presentations that were given.
Yes, I mean, these are only 3 slides from David's kind of, a very kind of helpful presentation. There are lots of other helpful ones as well. Okay, next slide, please. Okay, Cancer Buddies. Very much looking at Great Western Hospital, this pilot project, which is going from strength to strength. This is slides very much highlighting what were the key elements involved in setting up the pilots in the first place, and what were the important things that they found in order to make that work. Next slide, please. So clearly, in all these situations, we need to evaluate what's going on, what went well, and what didn't quite work so well, and therefore we need to do something about it. So you'll see in terms of what went well, focusing on recruitment, on matching, developing trust, and also very important to recognise the positive effect it had not just on patients but on the buddies. And then if you look at learnings, very much highlighting the importance of the need for a coordinator, particular technical point about the relevance of buddies having an NHS email account, the importance of training, the importance of supervision, and a number of other points that are being picked up there. I mean, I think the other one I would highlight is the whole kind of thing about buddies availability, and trying to clarify how available people are, because clearly, it's important for people not to be overstretched. Lisa, do you want to come in?
I just wanted to share, obviously, we had the buddies present at the June event, at our PPG event that we held in Oxford. And this was an opportunity for obviously to them to showcase to the wider network within our systems what they have achieved. The pilot has been a great success, and that is now being implemented as part and parcel of an ongoing project for Great Western. And it's a model that we've now shared with RBH because they were looking at doing something very similar. Unfortunately, Michelle wasn't able to join us today, but I just wanted at this forum just to give a shout out to those Cancer Buddies because the work that they've done is amazing. And from the showcase event, we've actually suggested to them that it needs to be highlighted nationally and see if there's other opportunities that PPG groups, which obviously the Cancer Buddies belonging to Great Western belong to, whether or not that similar model can be implemented in other trusts nationally.
Okay, thank you, Susan. Anyone else want to comment? Kate?
Hi there. I work at Bucks Healthcare in Cancer Information and Wellbeing, and on the back of that, in June we've set up our own Cancer Buddies project here, more focusing on the inpatient unit, so helping people, not the inpatient, in the treatment, the chemo suites, both in Stoke Mandeville and Wickham. We've recruited quite a few and are just starting. They've all just started now, and it's proving really successful as well. So it was on the back of that we got the idea. So yeah, brilliant. Thank you.
Yeah, it's always important to recycle good ideas.
Absolutely.
Okay. Anyone else? Any thoughts or comments on this? Okay, thank you very much then. Move on then to the next item. I'll be very brief on this. Next slide, please. These are just the highlights that I've picked out. The mapping, which we've already heard about, so I won't say anything more about that. Critical points, there's lots of discussion around performance, and then the NCPS update, which I'll talk about very briefly. Next slide. So performance, we're having, I mean, it's not just the Southeast, but you can see from here what the challenges are for the Southeast. If people aren't familiar with the term fair shares, as I understand it, that's got to do with the national NHS England taking account of the different size of cancer alliances, and so they need to be able to understand that in order to look how significant is a backlog, because obviously, percentages can be misleading. In Bob, we're third highest in terms of 60-day, 62-day and 104-day backlogs. And you'll see the point below that in terms of OUH and RBH. So not very good, but that doesn't mean that people aren't trying hard to deal with it. We are. It just reflects just the stretch that we've already touched on, and just the whole kind of thing about how challenging recruitment and retention of specialist staff is right across the country in cancer. Next slide, please. Faster diagnosis, already talked a bit about that in terms of David Fitzgerald's presentation, but you see we're just kind of slipping slightly on that. We were, well up there, but I mean it's only 1%. But I think it just reinforces how important we believe all this to be. That's all I've got to say in terms of the executive. We've got another one coming up in January. Next slide. And at the one in January, we're going to be reviewing the results of the last year's survey. That'll give me the opportunity to do a fairly significant presentation. But I think one of the points I have stressed is it's really important that we have the feedback from trusts prior to that in order to understand what their proposed actions are, particularly around the questions where we scored lower compared with the 2021 results. Kath, I see your hand up. Do you want to come in on this one?
Well, it was actually the previous one. I think that I've said it before at the delivery group meeting and also at this meeting. I think personally from a patient perspective, we need to see numbers of people, not percentages of slippage, because it might be, it might be a slippage of 2 patients. I know it isn't, but I think we need to know, is this 600 patients in the region that aren't being treated within the timeframes, 200, how many is it? Because I think it's great putting the figures out there, but we're talking about individual lives not having their cancer treatment, and we've just talked about the psychological impact. So if there's any way of getting those figures, I think it might make a little bit more better reading. Thank you.
Yes, I mean, Kath, when they do produce the figures, it's not just percentages, there are numbers, but I think this, as I understand it, I mean, Sarah, you might be able to help us in terms of this definition of fair shares.
Yeah, and I don't have all the figures here, but what I do think, and I agree with I'm sorry, I think we were Kath. I absolutely agree with you. What I also think is really relevant for people to see. I know in our trust in Swindon, so we're not in Bob, we're in BSW in Swindon. We're southwest rather than southeast, but I know our number of breaches are going up and up despite everyone's best efforts. But what we can also see in our figures is the number of cancer diagnoses going up and up as well. And I think those figures are really relevant, if as well as those breaches, but just the number of patients that are being treated increasing year on year. I think that would be really interesting and useful for this group to see kind of what we're dealing with on the backdrop of, and I know I'm boring, keep mentioning it, but on the backdrop of not being able to get more staff, of being really limited financially. I think all that information is really useful because I think people need to know what's going on. I think it's really important.
Yeah, no, I don't think you're being boring at all. I don't think we can reinforce too often just how stretched the system is, and just how challenging it is both to retain and recruit the qualified and experienced staff that are necessary. Anyone get any other thoughts or comments on this? I suppose particularly the previous slide and the data. I'll happily next time sort of try and report a bit more on the more detailed numbers. Although there is a technical problem which I've come up against, which is to do with the fact that not all the numbers presented at the executive are validated, and there's a slight reluctance to release until they are validated. But I'll do my best to try and focus a bit more on the numbers next time. Kath, you want to come back in?
Yeah, it's just to say that I think it's quite interesting for patients to also know about the workforce deficits, because because the other thing is, I mean, you know, we've all seen over a period of time so many new projects coming on stream. Well, you know, we're not just talking about the psych one, but others we've seen at this meeting, and we can't forever stretch an elastic band. And I think that, you know, somewhere along the line there needs to be a document that says we are, I know I've seen it somewhere else, but we are short of, you know, 50 CNSs throughout the whole of TVCA or something like that. So, you know, and I think that as patients then, well, you know, if you get cancer tomorrow, you'll want to get the treatment you want, and you want it when you want it or need it. But we do need to be a bit more aware, I think, of those deficits in workforce as well somehow. I don't know how we'll do that, but I think we need to be aware of that.
No, I think it's an important point, and I know it's something that, and we all know probably that it's something that Lindell has done quite a lot of work on and around the workforce. So maybe have a discussion with her and see if we can maybe do something maybe at the next meeting. Any other thoughts or comments? No, okay. Next item then. Lisa, this is you, because I think Kath was unable to be at the meeting. So over to you.
Great, thanks, William. So just so that folk are aware, with regards to our feeding and feeding out channels, William is the patient voice collectively from this group and the delivery group that feeds into our executive board, and Kath is the voice on our delivery group. So the hierarchy is executive board, delivery group, and then ourselves. So quite a lot of the items that William will share from the executive board, from the executive board, does feed into the delivery group. So with regards to the faster diagnosis standard, William's already obviously mentioned about where we lie in the southeast, and it is one of the three matrix that TVCA are measured on. We, you know, have been achieving the standard that was set for us up until sort of September. We were sitting, you know, first and second nationally. The regional team do monitor the position of FDS quite closely against the backlogs and across all the regional trusts, and they use a tool to plot on a graph with regards to the performance and if any of the trusts need to be tiered. And when I talk about tiering, it's looking at the patient tracking list, or the PTL. Now, thankfully, none of our trusts within Thames Valley are currently being monitored and being tiered, although we have had in the past. But Hannah and
I'm afraid that's not true.
Oh no, for Swindon.
So Swindon are in tiering, and I think Hannah might have some news for you too.
Okay.
Yeah, Oxford are also in tiering as well.
Well, that's obviously news from, I think, last week, or the delivery board. So apologies for that, ladies. So, well, that leads quite nicely onto system challenges then. So yes. Obviously there are stuff going on in the background, and, you know, various challenges, whether or not it's sort of winter pressures, ongoing effects of the sort of previous industrial action, and of course the latest junior doctors strike. And just, you know, looking into that, when you sort of look at the financial impact that that's had, with more than sort of 40 days industrial action that has happened, you know, it's created unavoidable financial costs. It's been sort of published that around £1 billion has been obviously the industrial action has cost, with an equivalent loss of elective activity. And although the government has actually given 800 million to systems, I know that a letter was actually sent out to trust execs on the 8th of November, asking them to work with their ICSs to identify, you know, the purse strings being pulled yet tighter, and when further monies can be saved. It's a possibility that any of the underspend that we've had across all programmes may be clawed back by NHS England, and that's, you know, obviously still to be decided with regards to the deficit and trying to make up that shortfall. So huge financial constraints, and obviously from system challenges it will continue. Business planning wise, so there's likely to be the same baseline levels we've heard around the core funding for cancer services next year, but this is to be obviously confirmed, and that will be probably mentioned in the operational planning guidance, which is due out imminently. Historically, it lands with us on Christmas Eve. We've had a draft copy already, but we haven't had the finalised version, and that should be, you know, as I say, imminently sometime soon. On a more positive note, as part of the delivery group, we had a lung prehab pilot shared with us. It was a detailed presentation regarding the pilot that was undertaken by Great Western, funded by TVCA. Early evaluation of the project has identified what the annual cost is likely to be going forward if it does continue, and what the cost saving is to the NHS. So there was huge agreement that it seems a sort of a bit of a no-brainer. You can see the figures there, but talks are currently sort of taking place with regards to the sustainability and how obviously that's sort of funded going forward. CPES, so William's already mentioned about the CPES results. The trust should have by now have presented their own CPES analysis to their boards, but of course for us to have a overarching view of what we're going to do within the Thames Valley collectively, we'll need to see those action plans from trusts individually. I know that I shared a more detailed analysis in September with you all, but obviously it's with buy-in from our colleagues within the trust as to whether or not, rather than replicate one project across all of the trusts, whether or not we can, rather than do it individually across the trust, whether or not we can replicate one project across all, and learning from each other. So William will actually be presenting to the board in January, and I think it's the first week of January that we've asked for all of the action plans to be shared with us, just so that we can give an informed presentation to them.
Okay.
And
thanks.
that's all I've got to share.
Okay, thanks very much, Lisa. Anyone got any thoughts or comments on that? No? Okay then, moving on. As we said earlier, Catriona isn't able to be with us today. Not the case. I did get that right, didn't I, Lisa?
Yes. So unfortunately, due to IT technical issues, she's not able to present, but she will come along to the March meeting and to share her thoughts on that.
Okay, item 7 then. Future dreams. Sarah, welcome.
Hi there. Hello. Thank you very much for inviting me to speak today. Lisa, are you in charge of my slides?
I am. So if you just want to say next slide, or Thank
you very much. So Lisa's invited me to talk to you today about a patient-led initiative that I've been involved in. I am a patient myself. I've been a patient. I'm not a medical clinician, so I know that there are lots of clinicians on the call, and this is coming from a patient point of view. I had breast cancer in 2016 and went through treatment over 2016-2017. Next slide, please, Lisa. I'm what one might term a patient advocate. After my own treatment, I set up an online support community called Ticking Off Breast Cancer. I've subsequently written 2 books from the patient point of view, and I wrote the patient chapter for the UCON's training manual. Since setting up my own online support system, I have now joined forces with a London-based charity called Future Dreams Breast Cancer Charity. Next slide, please, Lisa. I don't know if anyone has heard of Future Dreams. We are a London-based charity with the only dedicated in-person venue for breast cancer patients in King's Cross. It's open to everybody who has breast cancer or has had breast cancer or is living with breast cancer. There are no medical referrals needed to come along to the house. People can refer themselves, they can just turn up. There are lots and lots of activities on, workshops, talks, support groups. It's been up and running for 2 years now, and we're really just trying to find our feet in a way still. It's been incredibly busy, but there's lots going on. And what we're doing at the moment is moving a lot of our workshops and classes to online, because we want to encourage people who can't get to the house, whether they're based outside of London or they just don't, they're in London and they don't want to come along to the house, but would prefer to do something on an online basis. We're trying to encourage that. So that's our sort of current focus. But what I'm involved in at the charity is the information hub. And this is the slide you have here. The hub focus is patient-to-patient advice. It's practical advice for patients, people who have been diagnosed with breast cancer, given from the point of view of people who have been there or who are still going through it. And we're trying to provide helpful, practical advice to people during treatment, living with cancer and moving on after treatment. It's run by myself and 2 volunteers who have also, all 3 of us have had breast cancer. We don't have anyone on the team who is living with secondary breast cancer, but we have a network of secondary breast cancer patients that we tap into frequently. We tap into patient experience through the people who come to the house, the people who attend the online workshops, and a lot of our feedback comes via social media, because the charity is very active on social media. So we get a lot of feedback across there. We also run focus groups and things like that. Part of the hub is also to share patient stories, which I know was talked about earlier. We find that really, really important. It's really engaging for people to read about what other people have experienced. And we also have a selection of articles from more medical backgrounds, so people who are perhaps trained in cancer rehab exercise might provide an article about the benefits of exercise with some simple tips and so on. So there's a variety of information on the hub, and as I say, it's very much aimed at being a patient-led, patient-to-patient resource. Everything on the hub is checked by our in-house breast care nurse. We also have a breast cancer oncologist and a breast cancer surgeon on the board of trustees, and as and when necessary, we can refer to them. And so today I just wanted to flag up what we're doing, but also talk about a new initiative that we've just launched, which is our checklist initiative. Next slide, please, Lisa. We have just created 8 checklists for people who have been diagnosed with breast cancer. These are downloadable from our website and also available in hard copy. Next slide, please, Lisa. We've got 8 checklists at the moment, which are showing up on the screen now. We chose these because we had similar things available on the hub anyway, and they were very helpful. We got a lot of positive feedback about them, but people couldn't print them off, and so they were finding it difficult to refer to them on their phones or print them off. The formatting wasn't quite right. So what we've done is we have taken the checklists and we've refreshed them, reviewed them, had the medical sign off and so on, and made them just more accessible for patients. So we have hard copies that can be sent out to patients. We'd like to send hard copies out to the breast clinics and the breast centres and breast support groups across the country if people would like them for their breast cancer patients. And we'd also like hospitals and clinicians and medical teams to encourage patients to access them on their phones or laptops or whatever device they might use, because they can be downloaded and they can be printed off at home, but they also can be downloaded. So, you know, everyone's taking their phones into their appointments these days. We live with our phones, so they can download the checklists onto their phones easily. We have 3 more in the pipeline for next year: how to prepare for radiotherapy, male breast cancer, and fertility. I think I've mentioned everything. I'm just looking at my notes. Next slide, please, Lisa. Yes, this is just I recognise it's small, but I wanted to get the full checklist onto a slide so you can see the sort of thing that we have included. As I said, it's very practical based. We have put them together with the help of people who have been through this experience themselves. So, you know, it covers everything really. Next slide, please, Lisa. And yeah, just here is a slide with some more information, details. That's my email address at the top. I'm very happy for anybody to get in touch with me about the checklists or what we're doing generally. If anyone on the call would like to order copies of the checklists for your breast cancer patients, or if you could perhaps put us in touch with the people who might like them. Jackie at Future Dreams is the lady to contact. She's the breast care nurse. I've put the website up there, the URL for accessing the checklists, plus the hub homepage and the Future Dreams website. And that's it.
Okay, thanks, Sarah. And everyone will obviously, as usual, will get copies of the slides later on with the minutes. So all these will be available. Anyone got any thoughts or any questions or quick comments for Sarah? No, if not, Sarah, sorry, Lisa.
I would, thank you. Sarah, thank you so much for that presentation. I know when we were speaking, I wanted to kind of share with this group and sort of ignite examples where the partnership group has been able to kind of make a difference. And I know you're now a voice working with advocacy groups with NHS England, aren't you, about patient involvement and thinking of projects that can be taken forward. So I just wanted to thank you for sharing obviously this project, because it's sometimes hard to think of what projects people can get involved in unless examples are shared. And sometimes it's sometimes the simplest of ideas and a discussion around the table that can then grow. And yeah. I just wondered if there was any other comments that you wanted to share with the group around, you know, having that idea, having that spark, and who you then networked with to kind of put that into motion.
Yeah, thanks, Lisa. I just quickly answer because I know there's still a lot to get through. It's the simple situations. Actually, you know, a checklist is such a simple idea, but actually the reason why they're so popular is for various reasons. But one is when someone's diagnosed with breast cancer or a cancer, quite often a lot of your control goes out of the window. You lose control of many aspects of your life. You're constantly going to hospital for treatment, appointments. You have no control over the cancer. You don't necessarily have any control over your treatment. And so what we found a lot of people say is actually just if there are ways to bring back and regain control, then that really helps them from a psychological point of view as much as anything else. And so this is where this initiative came from. It's partly about taking back an element of control and having something that you can, as a patient, refer to, empower you to ask the right questions. A number of our checklists are suggested questions to talk to your surgeon about and chemo nurses about. It's giving the right questions. And just sort of going back to your point about getting the ideas, we get a lot of feedback from the people who come through our centre in London about what they need and what they would like. And that's really the best place just to have these cups of teas with, you know, somebody who's just popped in, and you're sitting there and you're having a cup of tea with somebody, and you can gather some ideas. You don't have to have a focus group. It's just having your ear open and listening to everybody and being in the right environment, which is easier for us as a charity because we have the time. I realise obviously a lot of the nurses just don't have the time for these conversations.
Okay, thanks, Sarah. Linda?
Thank you. I think it's a brilliant initiative. And just to say something we do forget, some breast cancer patients have never really had much in the way of dealings with hospital. And it is useful to have checklists and people to tell you what questions to ask, how to navigate the whole new area. So
yeah,
good for you.
Thank you. Thanks very much, Linda.
Okay, thank you. Thanks once again, Sarah. Take care.
Thanks.
Okay, moving on then. Next item. Katharina, are you with us? Saw her name earlier. Katharina, can you hear me? Maybe we've got some IT issues.
I've got, I can hear you.
All right, sorry. I just couldn't see you in the list. Okay, welcome, Katharina. Katharina was very much involved at the showcase event, and this is what she's going to be talking about today. I think it's important to just make the comment about, you know, at the event, I think one of the kind of strong things that came across was how little most of us know about paediatric oncology. And I think that highlights just how significant this project is. Katharina, over to you.
Thank you so much. I'm sharing my slides now.
Yep.
So can everybody see them?
They're just coming up.
Okay.
They're not up yet. There we go, yep.
Perfect, fantastic. So my name is Katie, and I'm very grateful that I have the opportunity to talk about my project today. I'm leading the experience-based co-design project to improve our aftercare and follow-up for pediatric cancer survivors after the end of treatment. And I want to just give a little bit of background information. So fortunately, over 80% of children that are diagnosed with cancer survive cancer. However, the toxic treatment consisting of chemotherapy and or radiotherapy and surgery might or can lead to adverse long-term health-related outcomes, so-called late effects.
Sorry, could you just ask you to pause there? I don't know whether anyone else has the same thing, but I'm missing some of the bottom part of your slide.
Oh.
You seem to have a black bar at the top and at the bottom, so we're missing some of the contents. I don't know whether.
Oh, let me just go back. Sorry about that.
No, technology is great when it works.
Let me see. Hold on. Try that again. Screen share. There. And share again. Are you able to see the full slide now?
Just coming now. We've still got black bars, but I think we can see more of it. So, yeah. Sorry, carry on.
I'm so sorry about that. I don't know why.
Don't worry.
That is the case. So these late effects contribute to a high burden of morbidity, with 60 to 90% developing one or more chronic health condition and 20 to 80% of them being severe or life-threatening complications during adulthood. The Clinical Oncology Group has developed long-term follow-up guidelines, which include recommendations for investigations and follow-up and monitoring organized by the therapeutic agent or whatever the person has received as part of the treatment. Looking at our region within the Thames Valley, we've got around 160 children, teenagers and young adults that are treated for cancer every year, and about 130 survivors who are eligible for an assessment within the late effect service. All of the survivors require that support on completion of disease monitoring, to help them to manage and identify late effects. And then we're using risk stratification, which I will show on the following slide, to group them into high and low levels of need of late effect monitoring. And then because of the thankfully very high survival rate, we are expecting this service to grow steadily. Looking at the risk stratification, depending on someone's treatment, they can be then grouped into level 1, 2, or 3, with level 1 being the lower risk survivors that are predominantly self-managed with GP advice, however, can be referred into our service whenever needed, and level 3 being the ones that have a high risk of late effects. Those might need input from various teams like endocrinology, and those will have regular follow-up appointments within our late effect service and clinics. Now, coming back to the project, the aim is to identify obstacles and gaps that stand in the way of an efficient and holistic service for our paediatric cancer survivors after the end of treatment across the Thames Valley. And we're doing that by bringing survivors and staff together to co-design work streams to improve the service during this project's time, which is over the next 9 months. But also we are planning to develop a roadmap for implementation for the next couple of years for ideas that might need just a little longer to implement in practice. We've chosen the experience-based co-design methodology, and especially the experience-based co-design toolkit that was developed by the Point of Care Foundation together with King's College and the Guy's and St Thomas's NHS Foundation Trust, because research has found those projects to be particularly sustainable, and also because the process is motivating for staff and engaging for parents, and it just really focuses on the co-design approach. This is an overview which I'm assuming now will be very small for everyone to see, so I'm going to go into those details anyways in the next slides. I'm just going to explain it while I go along. So basically, what happens initially is that we're conducting interviews with patients, parents, and staff. After that phase, and the patient and parent interviews are recorded via a filming company because it gives them a stronger voice and carries emotion better. The staff interviews will be in person with me, and I'll transcribe them. After that, there will be feedback events individually separately for patients and parents and staff members, where we look at the outcomes of the interview and then prioritize the areas found in need of improvement. And after that, there will be a joint feedback event where we'll watch the film that summarizes the patient-parent view. We look at each other's priorities, form shared priorities, and form work groups to start working on ideas for improvements within the areas found in need of improvement. Those work groups will then run simultaneously for 3 months and focus really on implementation of those ideas, testing and re-evaluation of them. Who are we including? We're including patients and parents and family members who have completed treatment, with Oxford being their primary treatment centre across the Thames Valley, and then staff working within secondary care within the Thames Valley, either in paediatric oncology or with the paediatric oncology team. And then we are not including paediatric cancer patients who are receiving active treatment or on the palliative care pathway. And we're expecting to improve our service structure, the patient experience, our MDD work, the clinical attendance. We are aiming to reduce health inequalities, empower patients, and recognize late effects early. This is the project timeline. I'm not going to go into any details. You can see we started in September. The project is due to end of July. Green is basically preparation and setup. The red section is what we've just about to complete, is the scoping phase. The blue phase is where we analyze the findings. The dark red section signifies or highlights the feedback events, and the yellow phase is where we'll have the work groups working on ideas for improvement. As I just hinted, we're about to complete the scoping phase, which included the interviewing of patients, parents, and staff. And I thought it would be interesting just to give a little bit of findings and information about the co-design process. So the staff interviews, I've completed 29 so far. They are semi-structured interviews. Questions include preparedness of patients and parents for the end of treatment, criteria for long-term follow-up, a few knowledge-based questions, and then what works well, what doesn't, how would the perfect model look like. A couple of results from the staff interview is in the green. You can see what they generally found to work very well. I thought I would just focus on those two areas, what works well, what doesn't work well. For them, they said the teamwork within the pediatric oncology team works really well. Everybody knows each other well, and communication within the team is great. Our holistic needs assessment that take place for every patient after they're diagnosed, and recently we started to do that for patients after the end of treatment, have been found very valuable. Those include psychologists, clinical oncologists. They also include the physiotherapy team, dietitians, the teachers, and many more members of the multidisciplinary team. And then in general, the consultant-led medical follow-up was found to be working really well. The areas in need of improvement were definitely the service structure, the guidance to how refer patients into the service, but also the pathway needs some streamlining. The pediatric transition into adult service is something that was found in need of improvement, and in general, the communication about the service, what it offers, what it does, and especially who can be contacted, is something that we certainly need to work on. And I personally found very surprising that there wasn't a lot of awareness of the late effect service at all for the vast majority of staff. So that's something that we'll definitely be addressing. Coming to the survivors and the parent and family members, a couple of highlights from their point of view is that they need a clear care plan and a treatment summary. They would appreciate a named point of contact and support that isn't just medical support. For example, psychological support is there's a huge need, but also educational support, career support opportunities, peer support is something that came up many times. And then just also signposting to other support available, for example, charities, and possibilities for them to come back into the service if they find they want to discuss something later down the line, for example, fertility for children that were treated early on, but then are reaching, you know, the age of 16, 17, 20. The whole project is based on patient, parent, and staff involvement. So we'll be hosting another focus group on the 16th of January, and we're appreciating everybody's input. Anybody that has had either cancer as a child themselves or is part of a family that someone has had that experience, we appreciate any input really, and be grateful to hear from anybody. The next steps are the staff interviews. They're due to be completed at the end of the week. We'll dive into the in-depth analysis of the interviews and observations in January, and then there will be the focus group. Now, I just would like to end on a couple of pictures from an experience-based co-design project that my consultant, Dr. Mitchell, who is kindly supervising the project, she has done this project, a similar project in Southampton, and I just think it's a nice way of illustrating the future steps of the project. So this is from a focus group event. This is my consultant, Dr. Mitchell, with her friend who is actually doing the filming for us. She has a filming company, Copia Productions, and they are looking at the editing of the film and the thematic analysis. This is then the feedback event for the patients and parents, where they watched the film and set the priorities. And then the staff have also set their priorities before the joint viewing event, where they then form different work groups. And then at the end, there will be a celebration event just to look at the learning from the project, the identify any ongoing activities, and look at the roadmap for implementation for the following years. I'd like to thank everybody that is involved in the project, and thank you very much for your attention. I'd love to hear your thoughts on the project, anything that could help us. Thank you very much for your attention.
Okay, thanks, Katharina. Any comments or questions for Katharina? Lisa, let's come in first.
Katie, thank you so much for the presentation. I know obviously you shared it at the showcase, but I thought it was really important for this group to kind of have wider awareness of sort of outside activities that involve patients. Unfortunately, Dawn Allen and Suzanne Brown weren't able to sort of attend today, and there are patient representatives from Henry Allen Trust and Owls Pals, which are obviously children's charities within the Thames Valley. And I was just wondering if there was anything that you would like as a group for us to either collate any information, or would you like me to share your slides with them if they haven't actually been part of your project for any additional feedback, or if there's anything that collectively as a group we can help to support you?
Okay, Katharina.
Yes, it would be lovely if you could share the slides with them. And I've met Dawn Allen the other day for an interview actually, and it's been an amazing experience, I have to say. She's doing so much great work, and it was really an enriching experience. And from that meeting, she said that we'll gather some kind of feedback within the parent group within Swindon. So that's really a great opportunity for me. Now, I don't know how many other groups exist, and I don't know how many of them might have to do anything with children that had cancer. But if there's any information you could give me on that, or any general feedback regarding the project, that would be fantastic.
Okay, well, there may be obviously wider groups, but obviously those two ladies are who I'm sort of linked in with. So it's great that you've already had that conversation with Dawn. And yeah, by all means, if you'd like to send me a copy of your slides, I can obviously then forward those on and include it as part of this pack anyway, and see if there's any feedback extra we can get for you.
Okay, thanks, Lisa. Kath.
Yeah, I was just going to say, it's such an important project that people are aware that there are late effects, and that although you may have been cured, there can be other consequences of treatment later on. So the more you can highlight it, I think, to people, then they'll be ready for that to happen. Maybe that's a good, you can look at that 50-50. Is it good or is it bad? But I think knowing that there could be late effects of the treatment is so important to patients, and a lot of patients don't actually know or think of that. This applies to adults as well, and I think the whole adult pathway as well needs probably to be looked at again, because and more research done in the consequences of treatment, because we cure people, but we sometimes leave them with more consequences of treatment. I mean, they may be here to tell the story, but yeah, but a great project, well done.
Okay, thank you, Kath. Katharina, anyone you come back on that?
Thank you so much, Kath, for that feedback. I also think it's very important to highlight, and it also applies, yes, to the adult sector as well. And I'm not sure how many of you are aware, but there will be an adult radiographer-led service in Oxford at the Churchill Hospital that will be opening soon. They're recruiting for that position in January. So yes.
Okay, well, thank you much, Katharina. Can I just ask one question? That the film is obviously a very important part of what you're doing, and obviously is going to be shown to those who have been participating. Is there any kind of thoughts about long term how that's going to be used?
Sorry, any highlights that will be
No,
used?
any thoughts about long-term, how the film is going to be used?
Yes, so we are going to share the film within the oncology networks that we have for children, but we're also expecting to share it within the Thames Valley Cancer Alliance. We are not currently planning to share it on any social media just because for patient protection and confidentiality.
Okay, well, I guess it'd be helpful, Lisa, if we were able to have it up on the website, but that's something we could have a word with Jill about.
Absolutely, yes.
Okay, well, thanks once again, Katharina, for that. As I said at the beginning, I think the whole kind of area of pediatric oncology is something which is, you know, very much kind of almost a Cinderella. You know, it seems to me, I think we could, in the cancer world, we can find a number of Cinderellas, and this is certainly one of them. Okay, thank you very much for all your work and for your presentation.
Thank you.
Okay. So we're still looking at the overall area of late effects, and David, I think it's over to you and your wonderful jumper.
Yeah. Hi. Thanks. So my name's David Charles, and I would describe myself as somebody who's living beyond cancer. I'm just going to say a few words about the OUH based late effects project, which is in the process of being set up. I don't have any slides, so it's mainly my impressions about what's going on. The very first thing I want to say is I'm very excited about this development. I guess partly for selfish reasons, but also because I'm aware that some of the concerns of the community of patients and former patients. I'll start by giving you a quick summary about my own situation, focusing on the period at and beyond the end of my treatment. And I think this serves to illuminate the issues that hopefully the proposed service will help to alleviate. So about 5 years ago, I was 60. I had retired a few months earlier, and I was unlucky enough then, of all times, to be diagnosed with an aggressive and rapidly advancing prostate cancer. My series of treatments, which took place between 2018 and 2020, was carried out here in Oxford, at the Churchill, and at the Royal Marsden in London. The final stage of my treatment comprised radical pelvic radiotherapy, which was directed at a range of widely spaced targets and former targets in my lower abdomen. This was partly precautionary and partly for reasons of salvage. I'm delighted to say that following my treatments, I am now, and have been, cancer-free for 4.5 years. Now, during the process of being discharged, this is back in the summer of 2019, I was told that the side effects from my radiotherapy would be expected to fade over the next few weeks and months as my body repaired the damage inflicted on it as far as it was able to do. I was also given information, though, that alerted me that I may experience further longer-term effects from my treatment. I was told that these could be trivial, almost significant, and on inquiring further, could come on between a few months at the end of treatment to several years later. So there's a lot of uncertainty both on the likelihood and the consequence, if you like. A few months later, I was formally discharged. So then time passed, and a year or two later, sure enough, I did then start to experience a kind of an uptick in some of the effects that I'd experienced during my treatment. And in some cases, an increase in their severity from what I recall when I was being treated. And also there were some new symptoms. I Googled how these delayed symptoms could change with time, fearing that they could continue to become more serious, and got involved, first of all, in the Pelvic Radiation Disease Association, the PRDA. They provided me with useful information and access to an online community of former patients who were experiencing symptoms after their own treatment. Forewarned is forearmed, as they say. And I found that getting information on the progression of these side effects and ways to manage them was very empowering indeed. Through the PRDA community, I became aware there were a number of late effects services around the country, providing support to former patients, but none in or near to where I live, here in Oxfordshire. Fast forward now to 2023. In the spring of this year, I became aware that there were plans to set up a radiographer-led late effects service local to our area. And this was specifically designed to cover Oxfordshire, Wiltshire and Buckinghamshire, something I was, for the reason I've just said, I was delighted to hear about. I spoke to Dawn Bowers from OUH and Emma here from Macmillan, and was invited to serve as a patient representative on the project setup. I feel strongly that this is such a good initiative because it's designed to support patients who have noticed changes in their body, are obviously concerned and may not know what to do about it, whether to go to their GP or get back to their consultant, which actually, as in my case, would be more involved because they've already been discharged back to primary care. So, some information about the setup. The process of setting up the service is being overseen by a steering group, which comprises healthcare professionals, staff from Macmillan who are co-funding the enterprise, and patient representatives. The service aims to provide care and support for cancer patients and their carers within the OUH catchment area. It's intended to cover psychological as well as physical symptoms after treatment. A pivotal part of the setup of the service is to listen to and consider the patient voice to ensure that from their perspective, the proposed service is accessible in a straightforward way and meets their needs as far as that's possible. It's expected that using personal experience and knowledge, the patient representatives who form a small but diverse group, at least in terms of their disease, will provide advice on how the service will be developed and hopefully constructively challenge the thinking of the steering group where necessary. Now, having recently received the formal go-ahead, the steering group will be considering staffing and how funding will be best used, the means of access by patients, how it should be advertised, what sorts of information resource it should hold, and how signposting to more specialist services should be carried out. So Emma, if I've missed out anything significant, please let me know. But that's all I want to say. Thank you.
Okay, thanks, Shepard. Emma, anything you want to add?
No, honestly, he's got it completely in a nutshell there. I can't sing this man's praises highly enough. So such a crucial member of our patient co-design group.
Oh, yeah. Come on.
No, I don't know if you have received any email communication with regards to this, David, but we have actually nominated you for a Macmillan Award.
Oh, no, I've not received anything. It's a good job. It's a good job that my pullover is red. Then you can't see my face. You know.
Okay. Vicky, you want to come in?
Hi, yeah, I just wanted to reiterate what David has said. So I've been working on the Southwest project as well, and we're just doing the evaluation at the moment, and there's some fantastic information coming out of that project already. They've been running for quite a few years, and all about the patient pathways and how many unnecessary appointments we can reduce by having this service in place. A lot of patients go to all different services before anything's even discovered, so getting rid of that is just so positive. And there's so many patient comments and that we can draw on from that as well of how they've been helped by this service. So it's really, really positive that we're starting to roll it out in the southeast as well.
Okay, thank you. And Kath?
Yeah, so this is for radiotherapy treatment, no chemotherapy involved, no chemotherapy. So I think there should be a project on chemo as well if there hasn't been, because there's lots of late effects of chemo, heart problems and skin problems. Well, it just goes on. So I was a carer for my husband, and he was told about the late effects very late on. He'd already had, I think, 4 or 5 rounds of his 6 lots of chemo. And one of the chemotherapy agents does cause heart problems, but 10 years on. So I think that, you know, we do need to consider these things. And like I said previously, is to try and, so maybe there's a chemotherapy project out there for somebody to tackle. But yeah, I'll leave it there. Thank you very much. But great project, Stafford, and good luck with it all.
Okay, thanks, Kath. And Lisa?
David, thank you so much for sharing. I know obviously on our backwards and forwards sort of emails, you mentioned about Mitch leading the steering group. And was there an ask that you were still looking to recruit other patients to sit on the group?
I think the view is we've now got 3 people from diverse backgrounds in terms of their disease. I think the general view is that's probably, I mean, there are some, as you are aware, there are some queries going out, and there are queries are going out to other organizations as well, the PRDA, for example. But I think that we may say thank you, but no thanks, depending on, you know, who comes forward. I think, would that be a fair situation, Emma, to say?
Yeah, absolutely. I think we're okay where we're at the moment.
Yeah.
And I think that because we're now in a position to move forward, it is maybe not the best time to bring new people on at the moment.
Yeah. I think there are some people in my own support group, for example, who want me to brief them on a close basis. So I think there are lots of people I will be feeding in messages and requests and calls for clarification as well, you know, from people I know.
That's great that you have that wider feedback.
Okay, David, thank you very much. I think you've just reinforced just how relevant the whole kind of area of late effects are, and how it's very easy for kind of clinicians focusing very much on let's get this focused, let's get this cure, let's get this solved, to, in a sense, you know, for that to be at the back of the mind. And as Kath has said, you know, it can be pretty significant, you know, some years later. So thank you very much.
Yeah, I mean, just to say, I know a few people. A very good walking companion of mine works for the United Nations in UNSCEAR, which is United Nations Safety Committee for the Effects of Atomic Radiation, and he was saying that, look, from his sort of international perspective, that this is a problem in inverted commas brought about by the fact that cancer treatments, including radiotherapy, are now allowing patients to live significantly beyond their treatment. Yes. And this is a problem, in inverted commas, generated by the success of cancer treatment. That Absolutely. This was not an issue, no. You know, a few decades ago.
Yeah, exactly. I mean, very much related to the longevity of all of this. So thanks once again, David, for that. Thank you very much. Okay, very briefly then onto the Lisa. I think you're going to report briefly on Jill's item.
I will, yeah. Let me just see if I can pull up the slides again. Bear with me just one moment.
We're getting there.
There's always a lag with these things, isn't there? Right, so hopefully I should be sharing my screen.
It's coming.
Okay, let me whiz to the appropriate slide. Okay, right. Am I sharing the cancer campaigns?
Yes, you are. Well,
brilliant. Okay, so unfortunately Jill's not being able to attend today, but I just thought I would give you an overview about what she's been working on. In quarter 3 for October and December, campaigns that she's highlighted are breast cancer awareness, mouth and throat, lung, Stoptober, pancreatic, and also the promotion of sort of Black History Month and International Day of Persons with Disabilities. As part of Q4, which will be January to March, they will include esophageal cancer awareness, prostate cancer, cervical cancer prevention week, World Cancer Day, Race and Equality Week, National Non-Smoking Day, and also Brain Tumour Awareness Day. So all various different straplines will be on our website, and there's various different social media promotions that she's doing on sort of Twitter or X, whatever you want to now know it as, and Facebook, etc. With regards to TVCA website, she's working alongside Kath and William. There's going to be a couple of videos produced in hope that we will actually promote further patient representation on this group. There's been various different campaigns to date, some with success, some unfortunately without. So it's trying to look at sort of outside the boxes ideas, and we thought it would be good if we could have, I think we sort of mentioned this in our last meeting, various sort of series of videos talking about what it means to be a patient and the patient voice within sort of the Alliance and sort of various different projects that are happening. As always, Jill would like to promote patient case studies as part of that sort of social media outreach and also on our website. So if there are sort of networks or case studies within sort of the support groups that our members are party to, she'd be really keen to kind of have that further conversation with you for putting involvement on the website. And I think that's all she wanted me to share.
Okay, thank you very much. Okay, next item then. Right, I'll be very brief. I already mentioned the national survey, but I think what we've heard a number of times today about are sort of real examples of our involvement as patients in various activities. And I would expect that the work that we're going to be doing on analysing the results are going to highlight more opportunities. So, for example, I know talking to Lindell recently, one of the things that they were beginning to talk about, this is around the whole kind of area about communication. I think we can't reinforce enough how kind of vital communication is, but between the clinician and ourselves. But we also need to recognise what the challenges are. And I think one of the challenges that Lindell and her colleagues were beginning to think about is just the whole kind of thing about language in various leaflets that are written, and whether or not there's more we can do, not just in terms of leaflets, but I think the whole, we know that the whole kind of thing about how we communicate, how vital it is. Now, it's not easy to, therefore, to sum up very, very briefly what some of the what that might mean in practice, but I think it's a potential example of the kind of thing that it would be very, very helpful to have members of the group involved in, if that's one of the directions that we end up going in. So I just really wanted to kind of highlight that as an example of some of the other things that we might be might be coming through, and also just to kind of invite anyone who has any thoughts about any other particular patient-led activities that either members of the group or colleagues would like to raise with us, so that we can look at how we can potentially promote those. So I suppose the key point I would like to leave you with is how can we as patients get more actively involved, so more actively along some of the lines that we've already been highlighting today. I think that's all I need to say. Final slide then.
I just wanted to ask, actually, though, given
Sure.
that an open opportunity, if people have any questions or queries around that, or any suggestions. It may well be that people want to take time out and come back to me separately, but I think quite often we have quite a lot of content in these meetings and we don't have an opportunity to delve into what those ideas may be.
Yes, does anyone have anything they'd like to flag up at the moment? Perhaps it's something you'd like to talk to those of you who are involved with. Kath.
Yeah, it's my old egg about screening and making sure people take up on their screening that's available to them. And also, I know that TVCA have do a lot of stuff on symptom promotion, i.e., you know, what symptoms to look out for bowel cancer, or what symptoms to look out for mouth cancer. But I think it is something that if we're linked to groups or linked to our, as I am, to our GP practice, that you can give them a prod and say, is it possible that you can put these up on your social media sites? So, you know, the more preventative measures we can take, the less people we are going to have going through our hospitals for treatment, if we can highlight what the symptoms are and to go for your screening, etc. Thank you.
Okay. Well, if anyone has any other thoughts, please do let Lisa know. I think that the other thing I think is really helpful is kind of for some of you to be in the situation where perhaps you can share a bit more at this meeting about the kind of things that your groups are getting involved in, so that example of, I suppose what David was saying earlier on, kind of just let's hear more from what's going on and see how we can perhaps share that good practice. So Lisa, dates for future meetings for 2024.
Great, thank you, William. So I just wanted to take an opportunity to thank everybody on this call today for their involvement for this year. I mean, without you obviously involved in the activities, joining these calls, sharing what involvement means to you and how you have been involved in helping projects, we wouldn't have a PPG. So firstly, I just wanted to say thank you for that. Going forward with regards to our PPG meetings, we've said that initially when we first established the group, that we should always be mindful about the schedule of the executive board and the delivery group to make sure that we have that feed in, feed out opportunity for us. So the executive board is scheduled on a quarterly basis, and we have the dates planned now for next year. They're highlighted there in yellow. And also, obviously, we have a deadline with regards to papers, knowing obviously those dates in advance and where content needs to be submitted is useful for both William and Kath, obviously, to prepare for that patient voice in those meetings. So that being said, these are the proposed dates that I've come up with for the PPG meetings. It falls a month prior to the executive board, and the agendas obviously for these meetings as per normal are circulated a week in advance. But I just wanted to hear from the group as to meetings to date we've scheduled from 1 until 3 on a particular Wednesday. If this sort of a time that people are happier with, if they wanted earlier in the morning, afternoon, evening, and of course, obviously to date we've had them virtually, with one just being face to face. So I guess probably are people happy to continue with obviously this rhythm, looking at obviously the dates that we've got, are people happy that they can attend, and if there's any sort of feedback about the meetings that we have had to date over this last year that members would like to comment upon.
Okay, Shaman, you got your hand up? You're on mute.
Doesn't seem to be working today. Sorry about that. So I attended the face-to-face meeting, so after lockdown that you had, and I was just wondering, can it be a mixture of online and face-to-face? I know, I appreciate it might be difficult in terms of location-wise for some people, but do you intend to hold face-to-face meetings in the future?
I think from a group's perspective, we have said that face-to-face is, far more personable and enjoyable. Obviously, there is a budget associated with that. Where we can, we obviously want to try and keep costs down as low as we can. It has worked really well with regards to virtually being able to host these meetings up to a point, which is why sort of earlier on in the year, we decided to have our first face-to-face group meeting. I think going forward, there probably is an opportunity for hybrid, but I can't sort of comment as to, if that's going to be once a year or twice a year. And as I say, there will be, a budget that needs to be found for that. So,
yeah. Thank you very much.
Any other thoughts or comments for Lisa? the point about timing, are people happy generally with this sort of 1 to 3 o'clock slot? Does that work for most people? I see some nods. Yeah, thumbs up. Okay, well let's stick with that. And certainly, I mean, I'd like us to get to the situation where hopefully one of these meetings was certainly face to face. I think we'll have to look at whether or not we can manage hybrid. I think hybrid's always helpful, but there can sometimes be kind of particular issues depending on the venue. So let's see what we can organise. But people happy with these dates then? Okay, right.
And I would just like to add and to reiterate that the content that we share, obviously, you know, we can tell you about all the projects that we're currently delivering within the Alliance, but this is your group as well. This is your opportunity to kind of suggest agenda items that you would like to see, you know, more detail given around. I'm conscious that the content that we have and the time that we have, we could probably just choose one topic and concentrate that whole meeting on it. And if that's something that you would like to do, then please do share that, you know, with me. And let's see if we can kind of have, apart from maybe CPES, some ideas that you would like, you know, to get involved in, or that you would like to have further discussions around, or showcase deep dives, as we call them, within the Alliance, about other sort of areas, early diagnosis, screening, prevention, personalised care, that you would like to have sort of more information on.
Yeah, I just reinforce that, because I mean, this is very much your meeting. I mean, it's Lisa's my responsibility to try to put together an agenda which is meaningful and helpful. But I think we always want to look at how can we improve it, how can we, you know, make it better so that all of us benefit from it. Okay, and with that, Lisa, I'll let you put up your final pretty slide.
Again, it was just to say thank you to everybody who joins this group and so actively who joins in the conversations as well. It would be a very lonely place if I was just talking to myself or to William on them. So thank you so much for your participation. And I hope, however you're celebrating the festive break, that you have a nice time and that you're able to celebrate it in the way that you would like, with close family and friends. So thank you.
And for me, thank you very much. Enjoy the rest of your week. Take care.
And we'll see you in 2024.
Yes.
Merry Christmas,
Bye.
Everybody.
Bye.
Bye.
Bye. Nadolig llawen.